Arbitochloric ICLs basically for keratoconus. But most patients with keratoconus are frustrated and unhappy with their glasses and contact lenses because the quality of vision is very poor, quality of life is poor, vision is not good, and they seek opinion for refractive correction. So most of these patients of keratoconus come to refractive clinics for an opinion, and most of them are picked up there. So decision making in such patients is a challenge, and most conventional procedures are not suitable for them for a refractive correction. It's basically progressive keratoconus involves a two-step procedure. First is stabilization. Stabilization is of utmost importance for a long-lasting correction. Treatment of keratoconus basically depends upon the age, onset and propagation of the disease. If it is a non-progressive kind of keratoconus, then you can just give them glasses, soft contact lenses if their best corrected vision is good, or RGP lenses, zero scale lenses. I think the speaker will be speaking on lenses for contact lenses for keratoconus. Progressive keratoconus requires invasive procedures to restore biomechanical stability. We'll have to correct the refractive error and the optical aberrations and halt the progression of the disease. There is a major transformation in how we look at managing keratoconus and the protocols, and it is a changing scenario like Krishna mentioned. And let us look at, this is my plan for treating keratoconus, young patients below 45 years, no scars. If they have a low refractive error and a good best corrected vision, if they're not progressive, then glasses or contact lenses. If they're progressive, then we cross-link them and sometimes combine it with a trans PRK. If it is a low refractive error with loss of best corrected vision, if it is non-progressive, then we just do the rings. I prefer Kera rings to improve the best corrected vision. If it's progressive, then we combine Kera rings with the C3R. Now we are using the accelerated mainly C3R. And if it's a high refractive error, good best corrected vision, then we do a C3R and then wait for some time and do an ICL. If it is a high refractive error, loss of best corrected vision, then we combine all the three. We do Kera rings followed by C3R and then wait for a few months and then the ICL. Coming to the main subject, toric ICL in keratoconus, we can either use it for primary correction of refractive error in a stable keratoconus, which basically is stable for more than 2 years, or it can be used secondarily after stabilization of progressive keratoconus with a cross-linkage. And if there is, or it secondary also can involve treatment of an eccentric cone with intracorneal rings and cross-linkage. So these results demonstrate the complementary goals and of the treatment modalities, and sometimes you may have to use a combination of these procedures. So when should you do the phakic IOL or the ICL? How long after cross-linkage? Again, there is a debate on this, and there are a lot of studies regarding stabilization after CTR. I give a minimum gap of 3 months and preferably 6 months after cross-linkage to allow sufficient time for corneal remodeling and stabilization. Of course, there can be changes up till 2 years, but whether you want to wait for 2 years, but basically these patients have poor vision and their lifestyle is affected. Even if you have 80% stabilization, and then I think it's good enough to go in and put because it's when you're implanting an ICL, your aim is probably to get the patient to probably 6-12 or better. It's not like a perfect refractive outcome. This is something you explain to the patient. So there may be a little bit of change, but that's okay. So 3 to 6 months is, I feel, a good enough time. So indications are stable keratoconus with high myopic astigmatism, K values of less than 52 diopters, and a central cone, apical cone, because the decentered cone has irregular more irregular astigmatism and loss of best corrected vision. So decentered cone may be defined as more than 50% of the cone outside the central 3 millimeter zone on topography. And then if you have a decentered cone, then I prefer to use a ring. So the implantable contact lens basically acts along with the natural crystalline lens to focus and correct vision. It is not a specific treatment for keratoconus, but it's just a refractive correction to give these patients better uncorrected vision. The toric ICL design enables both the sphere and the cylindrical correction, and most of these keratoconus patients will require a toric ICL. So it's quite easy to calculate the power. You have an online calculator, and then you get the diagram for rotation of the lens, which is very important, and you should have it in your OR. Loading of the toric ICL is the most important step, and 50% of the procedure you have to get the loading right. Getting the refraction again is a little tough in these patients. I mean, if you go back to the calculation sheet, you need to do the refraction. So the K readings and the K readings, the refraction. The cylinder is not based on the topography. This is something you have to realize. It is on the best corrected vision. It's on subjective refraction of the patient. So you do the subjective refraction and check the best corrected vision. Probably the least amount of cylinder. It is difficult to refract moderate and advanced keratoconus. You'll have to check for the best refraction. And then this is an example of a case 26-year-old female diagnosed with keratoconus both eyes. Right eye had a refractive error of -20 with 3 cylinder improving to 6/18. So we planned right eye ring with cross linkage with ICL. So first stage we did terraring followed by cross linkage, and then this reduced the refractive error to -14 from -20 to a 3 cylinder, and the best corrected vision improved to 6/9 parts. And after 6 months, second stage, we put in a toric ICL, and that gave the patient an uncorrected vision of 6/12 parts. And these are the topographies. You can see the mean K pre-op was 61 diopters, came down, this is the 8-month post-op topography below, and then it came down to about 55.4, and the best corrected vision was 6/18, and it improved the uncorrected vision was 6/12 parts. So if you have an uncorrected vision of around 6/12, then basically the patient can go about doing all the normal activities. It's my experience with the ICLs and keratoconus from January 2008 to December 2012, and progressive keratoconus was stabilized with cross linkage, and we used the standard Western protocol, and the minimum duration of between 2 procedures was 3 months, preferably 6 months. And the ICL was implanted under topical anesthesia with an intraoperative iridectomy. We used the V4 series in all these patients. We used 59 toric ICLs, and the regular standard ICLs were about 7. The inclusion and exclusion criteria. Inclusion criteria was age above 18 years, stable refraction, corneal packing more than 400 microns, antechamber depth more than 2.8, good endothelial cell count. We excluded patients with low packing because we have to do the cross linkage, antechamber depth of less than 2.8, poor endothelial count, corneal scars or opacities were excluded even if there were any peripheral marginal degeneration or autoimmune or connective tissue disorders. These are the demographics, and almost slightly preponderance of females or males. This age distribution typically between in the 20s to 30s. There's a pre-op refractive error. There's a wide range from low refractive error to up till over 20 diopters, but most of them between 5 to 15 diopters of spherical equivalent. So the pre-op best corrected vision ranged from 6/6 vision to 6/120. Most of them had better than 6/24 vision. Some of them were very regular cones, and then we used the rings for these patients. This was the post-operative uncorrected vision, and you can see most of them were better than 6/12. So you had a few patients who had even 6/16 vision, but these were patients who did not want keratoplasty, who wanted a solution the minus 20s, and you can't correct a minus 20 even with an ICL. You can probably bring it down, correct about 18 diopter. So they had some residual refraction. So if you look at the best corrected vision, you can see that most of them were better than 618, almost all of them. Which is good if you can avoid the keratoplasty. This preoperative best corrected versus post-operative uncorrected vision, which gives the efficacy, refractive efficacy of the procedure. You can see that most patients have between 1 to 4 lines of improvement, and only 2 patients had a slight deterioration. So these were the procedures performed. The ICL, orthopedic ICL with cross linkage was 91%, and then about 9% had a combination of all 3 procedures, cross-linkage, cross-linkage, and ICL. When we look at the other studies, Ali et al. Had similar results with vision being status quo in 50% of patients and the rest improving. Of course, we had a deterioration of about 7% of eyes. We had 3%. And the mean spectral equivalence also very similar. But the Joswell study, they selected patients whose best corrected vision was better than 6 by 12. So the results are a little better, and you can see that almost 94% of the patients had very good post-op best corrected vision. So to conclude, combined collagen cross-linkage with ICL with range is very effective and safe therapeutic approach of keratoconus, and can improve their lifestyle and their vision. Thank you.